Alterations in integument. Burns. Burns are tissue injuries that are caused by heat, chemicals, or electricity. The severity will be determined by the temperature of the heat source, duration of the contact, the thickness of the tissue that's exposed, and the burn location. Thermal injuries will cause coagulation of proteins in the cells. Chemical injuries actually liquefy the tissue and loosen cell attachment. Electrical injuries cause damage to the tissues or organs from the entry point to the exit point. Cardiac dysrhythmias, central nervous system complications can occur with electrical injuries. We see an inflammatory response that extends the initial burn injury, causing ischemia and tissue necrosis. More serious burns can cause a hypermetabolic state requiring increased oxygen and nutrition. With those more serious burns, we see fluid shifts and electrolyte disturbances occurring when the fluids move to the burn, causing an intravascular loss and fluid loss from the wound. We also see anemia, renal failure, gastric ulcers, and inhalation injuries occurring with burns. So true or false? Burns can affect fluid balance. This is true because it's a response of the trauma of a burn. And with that response, the fluid will shift. So we see edema. And not only does it result in edema, but the fluid's also trapped and unavailable to the rest of the body. So we can see decreased blood pressure because of that decreased fluid volume, and it can result in irreversible issues. Burn depth will be assessed from the color, skin characteristics, and sensation of the burn injury. A superficial burn is going to be a first-degree burn and similar to a sunburn. A superficial partial thickness burn does not cause scarring, or a deep partial thickness, which can cause scarring and require debridement or skin grafts, is a second-degree burn, and it's also dependent on the amount of the dermis that's burned. A full thickness burn destroys all layers of the skin and is pretty painless. The skin is charred and requires debridement. Fourth degree burns will involve ligaments, tendons, muscles, nerves, and bones. A quick initial method of estimating how much of the client's skin surface is involved is what we call the rule of nines, in which areas of the body surface are assigned multiples of 9. Another quick assessment technique is to compare the client's palm with the size of the burn wound. The palm is approximately 1% of the person's total body surface. And then we have the Lund and Brower method, which is the most accurate, but it might be a little difficult to use in an emergency situation. So true or false? A burn severity will be affected by the temperature of the heat source. This is true. The burn severity is affected by the temperature of the heat source, and additional factors which affect the burn severity would include that duration of contact, the thickness of the tissue that's exposed to the heat, and the location of the burn. Life-threatening complications include inhalation injuries, and these should be suspected when the client complains of a sore throat, singed nasal hairs, eyebrows or eyelashes, hoarseness. We see carbon in the sputum or edema of the face and neck. We see soot around the mouth or the nose. The client experiences shortness of breath or stridor. If burns occur to the face, neck, or upper chest, inhalation injury is always a possibility. Inhalation injury is associated with swelling of the airway, inhalation of carbon monoxide, and respiratory failure. And it may require mechanical ventilation. We also see hypovolemic shock from a decrease in the intravascular volume or infection. So true or false? An infection within a burn wound can be life-threatening. That's true. An infection within a burn wound can be life-threatening. The outcome of the burn injury will depend on the initial first aid and subsequent acute treatment. So the three complications can be inhalation injury, hypovolemic shock, and infection. The initial first aid priority is going to be to prevent further injury, smother the fire, and observe for respiratory difficulty. Oxygen and IV fluid would be administered as soon as possible. With acute care, we assess the extent of the burn injury and any additional trauma. We may need to provide oxygen and/or mechanical ventilation, definitely fluid resuscitation, may require a bronchoscopy, a tracheostomy, hyperbaric oxygen treatment, analgesics, or tetanus immunization. We need to remove the client's clothing to the burn area as soon as possible. We would clip and shave hair in that area, cleanse the mouth and lips, irrigate the eyes, cleanse wounds, and apply topical antimicrobials. There's two different methods of burn treatment, the open method and the closed method. The open method would require isolation, and we also need to keep the room warm and humidified. Debridement would remove the crust or the eschar, and an eschorotomy, which is an incision into the eschar, would be required if the eschar actually causes constriction or impairs circulation. And then the closed method is just what it sounds. It's the application of dressings and antimicrobials on the wound itself. Additional treatments to promote healing would include debridement, a skin substitute application, or skin grafting. Debridement is the removal of necrotic tissue, and it can be done 4 ways: naturally, mechanically, with enzymes, or with surgery. And a disadvantage of debridement would be bleeding. A skin substitute or temporary covering and skin grafting would cover large areas of burned tissues. It lessens the risk of infection, minimizes fluid loss, diminishes pain, encourages tissue regeneration, reduces scarring, and prevents function loss. Hypertrophic scarring can occur in large wounds when skin substitutes or skin grafting is not used. There's several different sources for skin grafts. Again, a skin substitute can be applied as soon as the wound is cleansed. An autograft, which is using the client's own skin. They remove a stamp-sized area of skin. We culture that and then transfer that into the burned area. We can also do a split thickness, full thickness, or slit graft to allow the graft to cover more area. And disadvantages include this: when you remove skin from one area to apply to another area, it causes a new wound and creates more pain, in addition to scarring from the donor site and risk of infection to the donor site, delay of wound closure, and increased medical costs. We can also get skin from human skin from cadavers. We can do the heterograft, which is animal skin. Following these treatments, we may use a pressure garment to help reduce scarring and wound contractures. Silicone therapy is the gold standard to burn scar management because it reduces redness, flattens the raised scar tissue, and improves elasticity. It can also be used with the pressure garments. So with our assessment, it's important to look at the wound and monitor the client's psychological status. We also need to do the calculation and infusion for fluid replacement requirements. We would treat for shock and pain relief in addition to monitoring for these. We also need to provide wound care with antimicrobials, dressings, we monitor for infection, and we provide emotional support. And client teaching. These clients need to exercise to help minimize contractures. They need to take in adequate nutrition. Maybe we need to educate about the use of pressure garments, skincare measures, and the use of sunscreen.